Our next presenter is a gentleman I've had the opportunity to work with on a number of occasions in different settings. And he comes from a very extensive background in alternative healthcare, having been an organizer and writer and executive in the emerging fields of complementary, alternative, and integrative healthcare since 1983. Mr. Weeks attended Stanford University and has received honorary degrees from Bastyr University in Kenmore, Washington, and the National University of Health Sciences in Lombard, Illinois. Mr. Weeks is known to many for his policy and leadership-oriented production called the Integrator blog, News and Report. He has served as a driving force behind the formulation of the Integrated Healthcare Policy Consortium, and subsequently organized and directed the IHPC's National Education Dialogue to Advance Integrated Healthcare, which was entitled Creating Common Ground. This effort, involving academic leaders from 12 CAM disciplines, including the chiropractic, naturopathic, and acupuncture professions, has led to the development of the Academic Consortium for Complementary and Alternative Healthcare, of which the Association of Chiropractic Colleges, Life University, and a number of individual chiropractic institutions across the country are members. It has been my pleasure to represent Life University in this environment, and it has been my pleasure in that context to work with Mr. John Weeks, who serves as the Executive Director of the Academic Consortium for Complementary and Alternative Healthcare. Here to discuss his variation of George Carlin's 7 dirty words are the 7 key elements within the Patient Protection and Affordable Care Act that would be of interest to persons with a complementary and alternative health orientation. Mr. Weeks.
Thank you. Nobody's ever given me license to talk dirty words before. It's a pleasure to be here, and I just want to honor Life for putting the program on. It's been a great program, and I think it's a sign of the kind of leadership we need to see not only in chiropractic but across the disciplines to get more of our practitioners, more of our educators engaged in the process that's going on out there. I was talking actually with Jerry about the realities with many of our fields yesterday, and he gave me a line about chiropractic, and I can say since I've worked across these fields that it applies to everybody, is that we all have an advanced degree in complaining post facto. And what we need to be doing going forward is figuring out how to get inside. And as yesterday a couple of speakers referenced their mothers up here, and I thought I would just say that one of the teachings from my mother was you don't actually complain until you get in and try to make a change inside. See if they'll listen to you, see if they'll allow you at the table, see what kind of headway you can make, and if you can't, complain away. You've learned the right. So what you're going to be hearing here is actually about this changing environment. It's a theme that's come up through a number of the speakers, and the opportunity to be involved in the dialogue is now so much more possible. Certainly for the other licensed CAM fields, it's a bigger deal, but actually, as you will see, chiropractic itself, which predated the other disciplines, has also got some more skin in the game formally. So I thought I'd first say that this consortium that I work with is basically the 5 licensed complementary and alternative medicine disciplines that have a U.S. Department of Education recognized accrediting bodies. That's the core membership. So that's chiropractic, acupuncture and oriental medicine, naturopathic medicine, massage therapy, and the direct entry home birth midwifery field. So those are the 5. They've all got that level of participation in the system, self-regulation and regulation. They've all got licensing. The naturopaths have the least at 16. Midwives are at 26. The acupuncturists and massage therapists reach at like 46, 47. And then, of course, you're in all 50 states. We also have a category. We decided to break the history with, this will come up in what I'm talking about here, of typically what we do in healthcare is you get inside the door and you slam it on everybody else. And when we were setting up our regs for what ACAC would be, we realized that in 1985 there was only one of these 5 disciplines that met our standard, that all of the other disciplines had gained recognition from their accrediting body since then. So we left a door open to the emerging disciplines, and that's who you see down below here, and that's, for us now, it's really yoga therapy, Ayurvedic medicine, and homeopathy. With Nancy Gales brought them into our conversation. Last thing on this slide is, one of our postulates was that if as a group we showed up, that perhaps we could open up some doors that you can't, or we've found at a hard time opening discipline by discipline. So this notion of CAM, which nobody likes, myself included, it was an umbrella that everybody was put under by those that weren't us. We've decided to say, well, what's the positive in that? And what you find out is that actually there is a great deal of philosophic alignment across these. There are theories around vitalism, for instance, in AOM, in Ayurvedic medicine. You know, it's chi in one field, it's the healing power of nature in another field. There's a lot more alignment there, and so we're saying, you know, what's the positive here if what we're all trying to do is create some thinking that focuses more on health? What can we do if we all walk into some of these doors together? I need to get my water, Jerry. You hear a lot about team and a lot about collaboration. Our basic operating idea is that we practice collaboration internally in order to stimulate it externally. We've been working ourselves and each other, and any of you who've been in legislation have known that often these disciplines have fought against each other state by state. This is just some of our meetings. It's a lot of people who've been involved. The middle meeting was last June that Jerry was involved with. If you looked closely, you would see a number of people you know. So here's part of what brought us together, what brought IHPC together also, was Senator Harkin in the late 90s saying to a group of folks who would form IHPC that it would help us in our work in beginning to look at CAM integration, which really grew in the late 90s, if you would come to the table with what some of your shared ideas are. And that brought many of us to say, well, let's figure out how we might be able to do that. I'm going to get into the language and the law here. It's good up front to honor the players that have had the most, biggest hand in creating these footholds, abutments, I like to call them, for bridge building inside of the system that I'm going to be going over. And, you know, it was a democratically controlled process, and so what you see is a lot of Democrats and somebody who's to the left of the Democrats in Bernie Sanders in VT in Vermont. I like this slide only because, you know, when you think about healthcare, there's no part of it where there was not a new foothold that was created in this act. You know, a lot of people thought, well, if you want to transform healthcare and do healthcare reform, we really should take what's going on and start modeling it around a whole person strategy. That's transformative, that's health reform, and short of that, forget about it. So what I'm saying here is, even though they, of course, didn't do that, there is not a place in thinking about healthcare and the important conversations where there was not some inclusion that was created. I'm going to go through these individually, but I thought to call your attention first to, if you look at the language that's used in describing who's getting included, you go from the non-discrimination bill, that's the licensed or certified, those who are licensed, have license or certification, at least in I was surprised Deborah said that it didn't have that, but it does have that in the language. So you see this licensed CAM practitioners, that's altogether new, you've never seen it before. Any of the language around integrative health practitioners, state licensed integrative healthcare practitioners, all of that language is new in this act, never was in federal law. The question about it, of course, is what the heck does it mean? It definitely came out of our work, and our work with Senator Harkin. That's the origins. Once it's out in the community, there are people who are seeing it and saying, oh, that means my doc and my psychologist and my PT should be talking to each other. So that's the integrative strategy we're talking about. There's not a lot of necessary clarity that anybody's going to look at that and know the origins. So this is an area that, you know, in the optimal proactivity, we would have all gotten together and figured out how to use the term from yesterday, brand this. I guess Weber was talking about, is develop the brand, say what it is, and put it out so people would know that it was talking about our disciplines. We haven't done it so well. There have been a couple of stabs at it, but haven't really owned the title as something that is in fact useful to us. I just want to give my chops to Deborah. She's not back yet. Oh, she's in the back here. You know, I was in Washington State through this process, and if we had not had that insurance commissioner, none of us would have had the example. I mean, she was laying out that history of, you know, there were these 3 lawsuits and these 5 times in the legislature they tried to take it away, and these were the personal aspersions that were thrown against me, etc. That went on for years. And Deborah hung in there with it. It was an amazing stroke of luck that she happened to be, you know, we did not elect Deborah. We happened to have an insurance commissioner who was supportive when this came up. One point on it, it was, you know, the act came through in March, April, when it was passed. Within 3 months, the House of Delegates of the American Medical Association had passed a resolution opposing 2706. The good news there, and Deborah talked about it a little bit, is part of the reason the every category provider piece went through in Washington State is they weren't paying attention because they had such a huge mess going on about other things that cost a lot more, that were more meaningful to them. And there's a chance we might slide through because the AMA and others will have their hands full with other things. I'd like to mention some of the orgs that have been involved. It's relatively limited yet. There's not a lot of people on the ground other than chiropractic representing these fields. Naturopathic doctors are getting their first, I think, real lobbying effort going on. They actually retained Deborah for that. The IHPC has got a new executive director, which I think will change some things, so that the ACA will have some more company in working on it. As we go through these others, I'm not going to read through the laws, but I thought it would be good for you to see where the language is. So this was in the medical home language in the law, and it basically says that, you know, when you are developing these, that these are providers who can be in them, and anybody who's worked with legislation will see that the language on the side there is may and not shall, which means that it's up to all of us to make sure that the may becomes real. But the fact that we're even being thought about is new there. And you can see there's the pattern here of the doctors of chiropractic being separately and independently listed. I can tell you that the other disciplines are envious, that they would like to be individually listed also. It is a shorthand for members of Congress and for other agency folks to be able to look at these fields kind of as a group sometimes, so you don't have to add to the list. So, again, you've been hearing about this. I just want to add a little bit from another field. The other discipline that really is kind of in this game is the naturopathic doctors, and I just learned yesterday that there was a major move in Vermont that's, I guess the vote's probably going to be today, that's going to give them the right to be running medical homes in Vermont. They have that right in Oregon right now. This part of the country is not where naturopathic medicine has any meaning. There's actually no licensing south of Washington, D.C. and west to Arizona. But where they are licensed, it's a broad scope practice that actually has, in most states, at least half the states, it's got a pretty broad drug right as well, which comfortably positions them for the common notion of what primary care is. We inside of ACAC have been working on a primary care project in part to help position our disciplines around this. The ACA, I know, and the ACC have used that document in some of the internal thinking, the chiropractic piece of it, and some of their internal thinking and positioning in this area. And of course, we had some involvement with Clem's work he'll be talking about with the Institute for Alternative Futures in 2025. We got Bill Meeker back to that meeting that Clem will be talking about in a minute. So the next piece, we talk about prevention and how important prevention and health promotion is to our disciplines, but until now we were not actually anywhere in the nation's thinking that there was any role for our disciplines, our way of thinking in that engagement. This was fascinating. Part of the origins of this legislation was through the Samueli Institute. It was Integrative Medical Dr. Wayne Jonas runs it. And actually, Clem's group was involved, IHPC was involved in some of the early thinking that developed this wellness initiative for the nation. If you can, for you who like holistic thinking, the fun thing about this initiative is that for in law right now, we have this idea with this section, that health is not just a function of what happens in Health and Human Services. Health is actually a function of what we choose to do with our energy policy. It has a function of what we do with our education policy. It's linked to what we do with our military policy. You name it. So they're representatives of all of these different agencies. They're developing this strategy together. Four out of the 5 early purposes use this integrative health language in talking about what they should be doing. It's a fascinating elevation. So just one of them is consider and propose evidence-based models, policies, and innovative approaches for the promotion of transformative models of prevention, integrative health, and public health. Now here's another piece that actually puts some rubber to the road is they're talking about who shall be overseeing this, and they say that there shall be, including integrative health practitioners and people with some expertise in that area. What's better yet is that of this group that I think is at about 19 or 20, there are 4 people that are identified as sort of coming from the integrative medicine world or coming from the broader complementary and alternative medicine community. Dean Ornish, I'm sure most of you know who Dean is, has been around a long time. Sharon Van Horn graduated from Andy Weil's program in integrative medicine. Charlotte's up at Tai Sophia. She's served on a variety of agencies through the years. She's a licensed acupuncturist as well as a variety of other things. Janet Kahn was the past head of the Integrated Healthcare Policy Consortium and is there in part because the IHPC nominated her and a group of folks got together and wrote letters in support of that. A fun thing that came out of that is that, so now we have somebody who's on this panel. Well, Janet sees herself as connected to these fields, so what she said is, you know what, I'd like to get some feedback from all these disciplines, so she came to us in ACAC and said, I'd like to do a conversation with your folks to get information from across the disciplines on what I can carry into this dialogue. And so on the 17th of January, we had this group that we put out a note to our list, and 35 folks showed up and gave Janet ideas on core questions that she had. Again, this is pretty high-level policy. It's pretty high-level participation. It's not about how you're going to get paid. But I'd suggest to you that that's the way things move, so at least more of the students that are here or were here, as they get out, they're going to see the environment shifted based on what's going on in advisory groups like that. This I actually haven't followed very closely, but it's notable that they've got a demonstration project that's now looking at an individualized wellness plan. New concept. Having wellness in the law is a new concept. The idea of individualized wellness is a new concept. Not new to you, not new to me. It's new to federal law. And as you look at the elements, nutritional counseling, physical activity plan, smoking cessation, stress management, plus some supplements. Anybody familiar with that? You know, there it is. It's in the law. I personally have not followed what's come of it, but first time out, nice sign. Suggests openness. The workforce piece created a lot of excitement that's fallen because it was never funded. But I think this is a place where, John, you could clarify this, that I think chiropractors were already in workforce planning before that. But for the other fields, it's the first time that there's a charge to say, well, when we're looking at how to meet our health needs, why don't we actually look at all of the licensed practitioners that our state legislatures have had the wisdom to license and see how they might participate in doing this. And so this was a very nice, it was great to see this, but the funding early on was not made available, and this hasn't moved as I understand it. This patient-centered outcomes research initiative, actually, it's, in my own mind, it's controversial. I love where they're going in some places, and in other ways, I just am very frustrated by it. If you look at the way they're defining patient-centered outcomes research, the way that they're trying to focus research around patient values, some of the language would be beautiful to any of you. I urge you to go to PCORI, PCORI.org, on the site. It's a quasi-governmental entity. It's going to have something like $600 million a year to spend on mainly comparative effectiveness research. It's a lot closer to what we need. It looks like a real research home for us. And as you can see, the language suggests that their board of governors needs to include a state-licensed integrative healthcare practitioner. And lo and behold, they did appoint Christine Gertz, who many of you will know. She's had a lot of leadership roles in the chiropractic field and in the broader complementary and alternative medicine field at NCAM, certainly in many of the most important chiropractic research initiatives, the big initiative with the Samueli Institute and the military now. So the value, I mean, the law said there need to have these folks. The law didn't used to say that. So you've got a chiropractor there. What happens is she was our founding co-chair of our research working group for ACAC. We've got access to her, right? She's somebody easy. We can pick up the phone and say, what's going on with this? She had a hand in putting together a listening session that I and a fellow named Carlo Calabrese, who's a co-chair of our research working group, were part of in Washington State last September to educate the Board of Governors about our disciplines, to try to get them to understand that if you're thinking about patient-centered, why don't you go talk to the fields that were grown based out of patients wanting them. Maybe there are a few hints about how to understand what patients want by talking to these fields. I can tell you that it hasn't been, my view of this, and it's really, it's raw observation, is I think that they get excited about this vision of doing it differently, and they really want to do something that's very different. And so the vision goes out and the definition goes out, but then when it comes to figuring out how do we actually make it so, they're retreating to, as the slide said yesterday, the old ways of thinking in order to do the new thing. And so the actual access is proving to be a little bit more challenging than many of us had hoped it would be, because the ways of getting to there are being defined by kind of old, reductive, single agent, placebo-controlled kind of modeling, rather than really thinking expansively. Again, why do you want to be at the table? As I said yesterday, a lot of this has been some of our hard learning is, simply from a human level. If you want integrative thinking, whole person thinking, to be part of policy, and you're asking a human being who was trained into reductive thinking, who's been practicing reductively for 30 years, and has been explaining their life to make that all okay for that long. And if you go to that person and say, show me the best model for looking at my work, show me the best model for covering my work, show me the best model for using and finding value in what I'm doing, what do you think is going to happen? This gets back to my mom rule here. We can't really complain. I mean, it's a human thing. Why expect that person to get you? Not very likely. This is a little side note. Midwives are feisty. And the licensed midwives wanted to be covered in Medicaid. They got themselves into the birth centers. Happened to be a user myself. I donate to their organization. We had our babies at home, both of them. It's a fascinating thing. My own view is, frankly, if we have full, thorough health care reform, and if you apply the triple aim that we heard about earlier, we will move our births out of the hospital back home, and that will be the way we'll transform U.S. health care, is giving people that message at that moment that they can do it without the machinery. So credit the midwives. I want to say, just to lock you guys in with the midwives a little more, I was speaking to them about a month ago, and I started my talk by saying, how many of you have used have ever used or referred for acupuncture? I did it first. It was like 95, virtually everybody put their hand up. How many have used or referred for chiropractic? Virtually everybody. Massage, I knew massage was going to be up there. Virtually everybody. Naturopathic doctors was still like 75%, even though they're only in 16 states. These folks may be the most integrated with all the other natural health disciplines of any discipline out there. So it's in all of your interest to have more births starting off out of hospital in the home. So I'm moving a step outside of the specific language to just talk about a couple of additional pieces that were changes in the law that have created real openness for our disciplines. And the first one here is, there was already an initiative on the books about investing more in a new whole pain strategy for the country. It was rolled into the Affordable Care Act. One of the first moves there was to then go to the Institute of Medicine, have the Institute of Medicine. It's a quasi-public agency. It's independent. And what they do is they put together these committees, get about 20 leaders on them, go through an intense conflict of interest process, and these people then come up with their recommendations that then, legislators use them, grant writers use them, people who are trying to shift policy they're used by a lot of folks to change things. We learned it was going on, and we thought to ourselves, let me see. How many people see chiropractors, massage therapists, acupuncturists, yoga therapists, for that matter, for GI issues, naturopathic doctors for pain conditions? A lot. So my board, this is the way we do this, my board charged me to call up the IOM and relay that message and ask, is there anybody from any of these disciplines on the committee? And they had no plan at that time. But actually these IOM technocrats, as we are learning, they're actually been we've got 3 relationships with them now. But they said, sure, give us a couple of nominees. And we gave them actually a chiropractor and Dr. Marinelli. Rick was the head of a large national pain organization, the American Academy of Pain Management, and they chose Rick. Partly because he was there. There's language that explicitly talks about complementary and alternative medicine and or chiropractic in about a dozen places. The next piece that I'll kind of move into my close on is that with the talk about team care, With the learning from To Err is Human, that study from a decade ago that showed all the deaths that are caused by care as we know it in hospitals, they tracked that and found, so what are the causes for it? And Crossing a Quality Chasm in 2001, they found out that disrespect between provider groups and lack of communication was a major factor in a lot of those errors. That began to stimulate the talk about we need to have more interprofessional education in our training. It didn't really lock in, however, until the financial incentives kicked in with the Affordable Care Act, where you can now get paid more. For instance, if you have a team at the handoff of the discharge from a hospital becomes a transition because you're actually handing that person off, you can make more money. So now there now is a movement that's growing. What you need to hear and get is it's taking the vertical world of physician-led healthcare and it's changing it. They're moving into this horizontal shared collaboration. There's people fighting back against it, but there's a lot of movement that's breaking down the old thinking, and you need to break down your own. They specifically say we see the value in patient-centered medical homes. It's a reason to do it. I close with this slide, which, so you know, there are these opportunities that have opened. Well, one of them that we in the Academic Consortium for Complementary Alternative Healthcare chosen to engage is one that is about educators. That's our base. Partly coming out of this IPE, interprofessional education movement, the Institute of Medicine decided to develop, the way they say it is we do these studies that are at the 50,000-foot level, but if we want to really drive action, then we do these forums that bring people together a series of times over a period of years to get to know each other, to begin to start thinking with each other, to actually collaborate together in developing programs. It was again shaping up. If you look at the list of folks here, the big six up there, as we call them, I guess I only grabbed 5 of them, sorry, the Dental Association should be with them, have been working together for collaboration. And in truth, there's a movement to go from kind of dictatorship to oligarchy and to just have the big six kind of running medicine and running interprofessional education rather than including psychologists, PTs, chiropractors, acupuncturists, and the like. So that's where the IOM began. We got in touch with them and through some foundation support and support that we're going to find and haven't yet, we're in this 3-year dialogue, which means you're in it. Life's involved with us. The ACC's involved with us. Our plan is to have an internal structure so all of our councils of colleges can give input into the forums that we're going to be developing. So this is really more to the educators in the room, but it's going to be 2 two-day forums a year for the next 3 years where, for those who have the taste for it, you can go and see what it's like to hang out with the leaders of all of these disciplines. As I share here, I got to say one last thing. Did any of you heard of the Future of Nursing report? Okay. You should know about this report. Came out at the end of 2010 and basically was a declaration of independence for advanced practice nurses. This is the Institute of Medicine and the Robert Wood Johnson Foundation, 2 of the most significant players of U.S. healthcare, saying we've looked at the safety data, we've looked at the effectiveness data, and nurses should have the right to practice without being overseen, whether as nurse anesthetists or in the primary care capacity, which has led the nurses to having roles in patient-centered medical homes. What I would like you to consider is that this is the biggest thing in medicine since the Flexner report. It took the sort of the hegemony, to use an old word, of the medical docs and it destroyed it. It's no longer there. They've now clarity that there's another discipline that can lead. And I would say that the MDs probably look at this like murder, you know. Once you've done it once, it's easier to do it the next time. And they've created an openness to begin to think that then perhaps other disciplines can also be in leadership and running things. that nursing report was an opening for everybody. That's a basis for this. It's a basis for the collaboration. It's a basis for the movement towards horizontal thinking. What we're bringing to this, and my last point is, and this was a charge from our board when we discussed this, a board of directors that runs across these disciplines. And just to say, we have an advisory council that's filled with integrative medical doctors, nurses. We work very closely with the integrative MDs in the med schools. We are not opposed to what they're doing. We think the integrative medicine movement is actually a good movement for patient care and for health care. We work with these folks. We, however, don't want to be run by them. We like this horizontal thinking. The charge we were given by our board was, wouldn't the most interesting and productive innovation in health professional education as we look to the next century, right? Wouldn't that be to be turning out health professionals who are very good at moving people towards wellness, towards health creation, towards, and this is a challenge for everybody, not needing any type of provider as much as they do right now? Isn't that the innovation that we should be pushing for? And so that is one of the directions we're going with the dialogue, and I should tell you that we're actually finding a good deal of receptivity. Thank you.